Endometriosis, it's actually a big topic, and that's my area of expertise. That's my subspecialty. I did this extra training in endometriosis because, let's put it this way, I feel it's not okay to have pain. It's not okay to have a painful period. So that's my role. In the clinic, I see people who come just sometimes saying, okay, we have painful period, and we were said by other physicians that it is okay to have a painful period, it's only in your head, which is not right. I think that that's actually what drove me to this subspecialty is no, it's not okay to have pain. It's not okay to be tortured every month with your period. So I digged more and I did more investigation in this area where I felt endometriosis is a big thing, but there are some treatment. There could be a relief. There could be patients who have endometriosis, but in the meantime they can be pain-free. They don't have to have pain every month. So causes of endometriosis is multifactorial, like there is different causes, but what we know about endometriosis, the main cause of endometriosis is that if the uterus has to menstruate every month, some of the lining of the uterus goes outside the uterus. So usually every month, what happens is the ovary releases an egg, and the uterus prepares the lining of the uterus for embryo, for implantation. What happens is that if the woman did not get pregnant, this lining shut down and have a period. What happens with endometriosis that for some reason these menses does not go down out of the vagina, they go upwards through the tube. So in other words, the lining of the uterus, where they should be inside the uterus, they came outside the uterus going into the pelvis. So they can go actually anywhere. They can go around the ovaries, around the tubes, around the walls of the pelvis, and that's the main reason of the pain. So basically when the next cycle comes, there are some of these tissue which should be inside the uterus are now outside the uterus. So outside the uterus, they think they are inside the uterus and start menstruating inside the pelvis. So in other words, it is menstruating outside the pelvis. And that's basically the whole scenario of it, where if something is happening outside the pelvis, first there will be some blood inside the pelvis, which makes the major part of the pain. So initially women presents with, okay, I have a painful period. We say that's the beginning of it. And then what happens, they start saying we have pain 2 days before or 2 days after their period. And when things gets more complicated and with time going, actually what happens is that there starts to be fibrosis or scar tissue inside the abdomen. When that happens, this scar tissues can cause significantly more and more pelvic pain, and now it's called the chronic pelvic pain. Other symptoms of endometriosis, and it's one of the biggest symptoms, and usually sometimes people come to the clinic and I have seen some people in the clinic complaining of dyspareunia, which means pain with sex. And that's also a big thing. So if we get the same theory that endometriosis is some of these cells that goes under in the lining of the uterus comes outside the uterus. It could go to the vagina, it could go to the pelvic side wall and causes significantly pain with intercourse. Initially this pain can be okay and the woman feels okay, maybe it's one time, and what happens is that it's building up and the pain is increasing one time after another, and it does not relate to any position. It's just pain that's getting worse and worse. Other than that, there get to be some other issues, which is infertility. And it is unfortunate. We know that endometriosis can decrease the fertility. Usually younger women present with endometriosis. And I have seen a patient few weeks ago who has been seen by infertility physicians for a long time, and we took her to the operating room for a diagnostic laparoscopy, and we found endometriosis everywhere, and that was actually the cause of the infertility. So endometriosis acts infertility in two ways. First, it decreases the egg reserve. Every woman has a certain amount of eggs, and with endometriosis it decreases this number of eggs. We have a test we do, sometimes we do it to see if these eggs are good enough or we need to do something about the endometriosis. Speaking again about other symptoms, and this is very common with endometriosis, is urinary frequency, and it got missed a lot of time with interstitial cystitis or urinary tract infection. So we have seen a couple of women who have been to the ER several times with urinary frequency and urinary infection. So they were labeled as frequent urinary tract infection, and actually it is not. It is, if we treated the endometriosis, she will not get that. The same idea, cells from inside the uterus goes to the bladder. The worst, if these cells went to the bowels, and these women sometimes get wrongly labeled as IPS, and basically it is endometriosis in the bowel, and they start having this episodes of diarrhea, constipation, bloating. This can be a little bit tricky because these cells, when they attach to the bowels, they get the bowel very irritated, and it's actually something that's very concerning because sometimes it can turn into chronic fibrosis and chronic bowel issues. In terms of the risks, endometriosis, the good thing about endometriosis, if we discovered endometriosis early and started treating it, we will avoid most of the risks. The risks of endometriosis, if these endometrial cells went into the ovary, first, as we spoke, it will cause infertility. And I can't see anything more devastating than some woman trying to get pregnant in their childbearing age and waiting for years and years, and eventually it's only endometriosis that can be treated. The second is sometimes the endometriosis can form a cyst inside the ovary, and it's called an endometrioma. In medicine, we call it a chocolate-like cyst because it looks like a chocolate with a dark brown appearance. And if this cyst became bigger, more than 5 centimeters, it can twist around its blood supply. Again, if that happened, there is a very, very high risk of something called ovarian torsion, which means that a woman can lose her ovary if that's a big ovarian endometrioma. Usually the treatment for this is surgery. Other risks of endometriosis is, as we spoke about, bladder issues, bowel issues, and there is a very strong link with endometriosis and depression. There is a study showing that chronic pelvic pain secondary to endometriosis increases the risk of depression. In terms of long-term risks of this, it's unlikely, but there is a risk of cancer of these endometrial cells going outside the pelvis, and with excess estrogen they can proliferate more and increase in size and size. So diagnosis of endometriosis is a little bit tricky because there is the only diagnostic way to do it is diagnostic laparoscopy, to put a camera in, get some of these cells and look under the microscope. But of course we are not going to do this for every woman who comes with pelvic pain or painful period. But we can narrow this in terms, first of all, the exam, the pelvic exam. With the pelvic exam, there are some features that we can see that actually narrows our diagnosis. Okay, this might be an endometriosis. Like there are some pain or nodules inside the pelvis. The pelvis, usually the uterus should be floating inside the pelvis. It doesn't have to be thick or stiff. One of the best ways to diagnose the endometriosis is to examine the patient. And unfortunately, some people, like pelvic pain, okay, they don't examine the patient. And that's the main way to diagnose the patient, first is examination. The second, there are some ultrasounds that we can order to try to narrow our differential diagnosis. So if we see some features of the ovary, this can tell us, okay, this might be an endometriosis, like an ovarian cyst that looks like an endometrioma or chocolate cyst. This can narrow our diagnosis. Okay, this patient might have an endometriosis. I have seen a patient last month who had this bowel issue for 5 or 6 years, and then she did a colonoscopy. They did a biopsy from the colonoscopy. It came back to be endometriosis. But again, that's not the usual way to diagnose it. Like, it's not to do a diagnostic laparoscopy. It's not to do a colonoscopy. It's to do an exam and ultrasound. Sometimes we use MRI if we are still suspicious, but we typically start with just the exam and ultrasound. But again, diagnostic laparoscopy or colonoscopy or even cystoscopy, where we look inside the bladder or looking inside the rectum, is not the first line of diagnosis. The first line of diagnosis will be the history and the pelvic exam. So we don't need to do a diagnostic laparoscopy for everyone, but we can certainly do it for some people. Again, if we start by what's the cause of endometriosis, is endometrial cells. And these cells usually grow with a hormone that each woman produces at the first half of the cycle. It's called estrogen. So our aim or our goal is to decrease this estrogen level. So first we try some hormones, and birth control pills is an option. But birth control pills has multiple and different forms. So we use something with low estrogen and high progesterone. That's usually our first line of treatment. Sometimes this does not work, so we omit the estrogen completely and we only use the progesterone pills. The progesterone pills can sometimes get things under control. And all of that is considered our first line of treatment. Then the second line of treatment is using higher types of hormones, and it's basically shutting the ovaries, making the ovary think that this patient does not need her ovarian hormones, and it is a hormone that gets injected, or some of them are oral medication. It's called GnRH agonist or antagonist, but basically it's an injection or a strong oral medication that shuts the ovary for some time. The question is, and that's what I get from lots of the patients, will I use this for the rest of my life? And it's not. It all depends on what's the aim and what does the patient need. So if the patient is thinking of getting pregnant soon, then we use a specific types of hormones in order to get her pregnant. And guess what? If she gets pregnant, the endometriosis will decrease or even disappear. And that was funny because I spoke with a patient and I told her, okay, get pregnant and your endometriosis will disappear. And she kept laughing because she was only 90 and she didn't want to get pregnant now. So pregnancy is also one of the treatment, but it depends on the patient goal. If all the treatment options did not work, then our next step is to go for surgery. Surgery is basically removing this abnormal cells that's inside the pelvis, lysis of the adhesion, because once the fibrosis happens, it keeps building up. So we're trying to cut this cycle by just lysis of these adhesions, removal of these nodules or endometriosis from the pelvis. The issue with surgery is that the recurrence rate is high. So the patient who is willing to do surgery, she's gonna promise that she will start the medication soon after surgery, because we want, like, if we cleaned everything, we want it to remain clean. And the way to do that is to just clean everything from the pelvis through the surgery, but then put her on a suppressive medication until either she wants to get pregnant or to give her the medication to decrease the endometriosis again. If the IPS is either a wrong diagnosis or it is an associated secondary to endometriosis, basically if we treat the endometriosis, then we are improving the IPS symptoms. We are improving the urinary symptoms. And some people find it very impressive once they started the medication. After a couple of weeks, they did not require to use their IPS medication, and their bowels started to become regular as normal. So if I want to get one point of this, diagnose it early, treat it early, rather than waiting and getting into the complication or more risks of the disease. Get your regular checks, get your annual exams, get your Pap test. And speaking about the Pap test, there was a woman who haven't had a Pap for 7 years, and when we were doing her Pap, we found these endometriosis cells in the vagina. So she was having this pain with sex, pain with her periods, and she was kind of letting it go, like she was ignoring that. So regular exam, regular Pap is very important. In our residency, we do obstetrics and we do gynecology. Get a gynecologist who do lots of gynae, lots of GYN, where they specialized in these forms of pelvic pain and endometriosis. This will help a lot to narrow your diagnosis, narrow your symptoms, and also help you in the treatment. Most of the insurance cover the annual exams, and every woman should have their annual exam. It's not only for the endometriosis, but we can and we did pick a lots of diseases just by the annual exam.